Hello, everybody. Welcome to this webinar. My name is Andrea Borgo. I come from University Hospital of Padua. Padua is in Italy, in the northeast part of Italy. I'm an orthopedic surgeon. So before starting the webinar, I have to remind you that you are not allowed to take any screenshot. You cannot reproduce any of the slides, and you can submit the question with the proper panel in at the end. We are going to try to answer to as many questions as possible. So, what are we going to talk about today? We are going to talk about the orthopedic aspect of mucopolysaccharidosis and alpha-mannosidosis. And in order to recognize some precocious aspect, musculoskeletal signs that are able to orient to a diagnosis and to understand the surgical option and the timing of the surgical option with from an orthopedic point of view. So what are we talking about? By definition, mucopolysaccharidosis and an alpha-mannosidosis are an hereditary lysosomal storage disorder that are caused by the lack of function of an enzyme. In MPS, the enzyme is required for the degradation of the glycosaminoglycans that are better known as the mucopolysaccharides, that are better known as glycosaminoglycans, and in alpha-mannosidosis, the required enzyme which is lacking is by the degradation of the oligopolysaccharide. And you are probably familiar with this biochemical classification. I put the name of the disease, the eponymon, with the name of the doctor who very first described the pathology, the enzyme that is lacking, and the glycosaminoglycans, so the oligopolysaccharide that are stored. I have to say that there is a wide range for alpha-mannosidosis. If you go deeply to the literature, you can find alpha-mannosidosis type 1, 2, and 3, or in other classification 1 and 2. But from we can say that there is a broad spectrum of disease that is characterized basically with a very attenuated form, that is the one who develop all the orthopedic sign, a very severe one that lead to early death because of the involvement of the central nervous system and the recurring infection. And obviously, this very severe form is not going to develop any musculoskeletal alteration because of the sudden death. And from an orthopedic point of view, we can have short stature, muscular weakness, joint stiffness, ossification delay, and in the hand, trigger finger, carpal tunnel syndrome, in the spine, instability of the upper cervical spine, the very typical thoracolumbar kyphosis, in the hip, we have hip migration, hip arthritis, in the knee, genu valgus deformity, knee arthritis in young adults, in the ankle, we have ankle valgus deformity, and later on ankle arthritis. And I try to resume all the orthopedic aspect in this, let's say, orthobiochemical classification. But we are going deeply and deeply side by side to see each one of these aspects. So I have to say that the interest from the orthopedic community about, I say, all the metabolic disease, and especially mucopolysaccharidosis, and lastly also alpha-mannosidosis, is getting common and common. I remember that no more than 10 years ago, we were very afraid to manage with this kind of disease, but now I can show you there are a lot of very orthopedic journal talking about metabolic disease. And I have to say, first of all, that from the lack of the enzyme to the final phenotype, the mechanism is not clearly understood. There are a lot of things that we still don't understand. We can start from three major observations. We have in mucopolysaccharidosis at least an alteration of the chondral ossification system. We have an inflammatory reaction, and we have a storage of the gags inside the soft tissue. We have also, coming especially from the very recent literature, some other observation like the alteration of the autophagy, the interference with the growth factor, apoptosis compromission, and so on. But I like to go deeply and deeply in the alteration on the enchondral ossification mechanism. And so I like to start from these two electron microscopy. In the right side, we have an MPS chondrocyte. In the left side, we have a normal chondrocyte. And the difference is very easy to see. What we see in the pathologic chondrocyte, we see that there is the chondrocyte is enlarged, the cytoplasm is all filled with vacuoles, and the organelles are reduced in number and in the strength, and they are displaced toward the plasmalemma. What happened later on? That some vacuoles open into the extracellular matrix. At the end, we find some rosette-like deposits. And this is the very beginning of the problem in MPS. I don't know if you are familiar with the histology of the growing plate, beginning from the reserve zone to the proliferative one and so on, but without going deeply, I like to show you that there is a well-organized in column histology that is completely lost in MPS, like you can see in the right side of the monitor. Also in alpha-mannosidosis, we have a storage of inside the cell. Unfortunately, there is no report about exactly the bone tissue. I like to show this lymphocyte that is strongly reminded what we said before for the chondrocyte in MPS. And when does the problem begin? Very early, because I like to show these two samples of a human embryo. And this is thoracic vertebra in the very transition from the mesenchymal tissue to the cartilaginous tissue, and it happened between the 5th and the 7th week in the prenatal life. So if you remember that the beginning of the problem is the alteration and chondrossification system, you can easily understand that the problem is really begin very early. And if we want theoretically to act with a therapy that is really able to prevent all the manifestation, we should start before birth. So, are the therapies nowadays available for MPS able to prevent completely the orthopedic manifestation? No, the answer is no, and we have some clinical observation. The ERT leads to a faster growth, reduce the stiffness, reduce the weakness, augment the bony mass, but have a poor effect on skeletal deformity. At the bone marrow transplant, we know if it is done very early, the skeletal deformity go an attenuation, the skeletal deformities is seen, but they are still present. There are also some experimental studies with new experimental therapy that are not until now performed in human, but the results are often the same, are still the same. I mean, poor effect on the musculoskeletal system. So we observe in mucopolysaccharidosis dwarfism, I mean short stature, muscular weakness, joint stiffness, sophisticated inlay in the spine, platyspondyly, thoracolumbar kyphosis, hypoplasia of the odontoid process, cervical myelopathy, lumbar radiculopathy, and later degenerative arthritis later on. In the upper limbs, we observe trigger finger, carpal tunnel syndrome, and radial deviation of the distal radius of the wrist. In the lower limbs, we observe hip dysplasia and valgus deformity of the knee and the ankle, and flat foot with the later degenerative arthritis later on. Often we say that alpha-mannosidosis is very similar to mucopolysaccharidosis, but if we go deeply into the literature, we find no report about dwarfism. They almost have normal stature. We found no report about ossification delay. We find the muscular weakness, yes, and we find the stiffness and the contracture, but we found some report about scoliosis that is said to be typical of the alpha-mannosidosis, and can be also present in mucopolysaccharidosis, but this is not typical. Scoliosis it can be present in mucopolysaccharidosis, but this is not typical. And we find no report about hand alteration in alpha-mannosidosis, and we find no report about flat foot. We find in the severe cases some equinox foot deformity. But I hate to say that alpha-mannosidosis is also an ultra-rare disease, and there are only few reports. And I like to underline that only moderate cases survive into adulthood. And so what we can find in literature is poor about alpha-mannosidosis. And so sometimes we can state that if there is no report about some aspect, maybe it's only because the moderate cases are going to survive into adulthood. And so going deeply and deeply, about the short stature, we can see that it's very common in MPS, especially MPS 1, 4, and 6, while MPS 3 have a normal stature. And as I said before, there is no report of short stature in alpha-mannosidosis. I underline only from the moderate cases. MPS 2 as an exception, because before age 8, we can also observe a higher a stature higher than average, leading anyway after 8 years of age to a short stature. And the stature is short and disproportional, like I wanted to show you in this slide, where the shortening of the trunk is prevalent, while we have only a mild shortening of the length. So short and disproportional. What about the stiffness? The stiffness is very typical of this lysosomal storage disorder, and this is usually painless, symmetric, without any sign of inflammation. In young patients, the stiffness is mostly due to the storage of the glycosaminoglycans in the soft tissue. I mean, if we take an X-ray of this young patient, for example, the joint line and the shape of the bone are almost normal. In adulthood, in addition to the problem of the soft tissue, we have the dysplasia of the bone. So if we take an X-ray of an adult, we have also alteration of the joint line. But this is typically not present in children, and probably this is why the enzyme replacement therapy is able to have we observe a stiffening release with the enzyme replacement therapy in younger patients. Dosification delay is typical of mucopolysaccharidosis. I underline not reported for alpha-mannosidosis, but I have also to say not sufficiently studied, and this is more evident in carpal and tarsal bone. What about the spine? We can have some mild situation, like in this case of mucopolysaccharidosis 3, Sanfilippo syndrome, or in this case of alpha-mannosidosis, and we observe only the irregular profile of the vertebral body with this slight platyspondylia. But we can have also some severe cases, like in this Martolami case, where we observe the early onset of the thoracolumbar kyphosis. So, what are we going to do for this thoracolumbar kyphosis? Are we going to use the anti-gravitary bracing for all the life? Are we going to operate all them? I have to say that this is not well defined in literature, but there was a consensus conference for MPS 1, and we can get our inspiration for this consensus conference, where it was stated that the anti-gravitary bracing is useful to postpone the surgical treatment and is useful to manage the postoperative period, while the indication for the surgical stabilization is the pain plus the sign of myelopathy. Once upon a time, years ago, I mean, we were more, we look at the deformity progression, but from this consensus conference, it seems to be not so important, why the pain and the documentation, the documented myelopathy are more important. And the proper age to perform the stabilization of the column of the thoracolumbar kyphosis is between age 5 and 13, and that's why, and this is because before age 5, these are a higher risk of implanted failure, while after age 13, the deformity is stiff, very stiff, and almost impossible to correct. In the spine, we observe commonly some joint instability that can be in the upper cervical spine or in the lower part of the cervical spine, a compression due to the glycosaminoglycans storage in the periarticular tissue, or a combination of both. Like in this case, for example, we can see a compression in the upper cervical spine, or in this case, for example, Morchio patient, we can observe an instability that is well documented in extension and flexion X-ray, or in this magnetic resonance. And this is, by the way, the treatment we did with the occipital cervical fusion. Or we can have some other case of instability of the lower part of the cervical spine, sometimes very difficult to manage also from an orthopedic point of view. The stiffness, we already talked about the stiffness, but I like to underline that the stiffness is severe. If you look deeply into this picture, you can see that the real abduction of this young girl is no more than 45 degrees, and she is aged only 3.5. And there is a wide compensation between the scapula and the thorax. So the appearance is that she opened the arm 90 degrees, but in reality, the real movement of the shoulder is no more than 45 degrees. And there is a stiff elbow, a stiff hand. Sometimes this stiff elbow and the lack of pronosupination can be one of the very early signs of metabolic disorder. So in case if you see a young child with a stiffness without sign of inflammation, all with a symmetric, painless, and so on, think about metabolic disease and mucopolysaccharidosis, because it's very easy. It's very easy that you are with the proper diagnosis. And the same for the carpal tunnel syndrome that is often reported in mucopolysaccharidosis. I like to present this famous study that is in the presence. It considered 163 children with carpal tunnel syndrome, and we can say that almost half of them have a mucopolysaccharidosis. So, in presence of a carpal tunnel syndrome, please think about a mucopolysaccharidosis, because the carpal tunnel syndrome in a child is really uncommon. So if you already know that the patient has a mucopolysaccharidosis, please check for the presence of a carpal tunnel syndrome, because I can say, like it is resumed in this table here, that almost in 50% of the patients develop a carpal tunnel syndrome, with the exception of MPS 4. And there is, I have to say and to underline, no report about carpal tunnel syndrome in alpha-mannosidosis. What about the carpal tunnel syndrome? If you decide to operate them, there is no room for the mini open procedure that we are used to do in young adults, in young healthy adults, I mean. But we have to do wide opening, because we have to remove all the glycosaminoglycans that are in the perineum, in the soft tissue. You have to remember that there is also an MPS associated neuropathy. So the compression in the carpal tunnel syndrome is one of the problems, but there is also an MPS associated neuropathy. So the transverse ligament is really thickened, and you can see it in this slide. I'm sorry for the deformation. And what about the trigger finger? The trigger finger can be present in a child without thinking about metabolic disorder, but generally it is the thumb. So the thumb can be, we can observe a trigger thumb in a healthy child, usually between age 2 and 3. But remember, if the trigger finger is one of the other finger, I mean, excluding the thumb, this is really uncommon, because it's really strange in a child to have a trigger finger that is not the thumb. So in case of a trigger finger, like in this case, that is one of my patients, by the way, that the first sign was a third trigger finger, and it was a mucopolysaccharidosis. So think about a metabolic disease, especially a mucopolysaccharidosis. Can we do something for this flexion contractor and this thumb contraction in mucopolysaccharidosis? Yes, we can do some release, because this is a very orthopedic and very surgical topic, but we can cut the A1 and the A3 pulley in order to have some release, and at the end children are able to open widely the hand and they have a better function of the hand. So what about the lower limb? I'd like to present this result from a study by White and Armath, and we can see that the presence of hip dysplasia or proximal femoral epiphyseal dysplasia is very commonly reported in MPS adults and also in children. I'd like to present this outcome that is, I don't know if you are familiar with the POSNA outcome score, that is a functional score that in orthopedic pediatrics, the orthopedic pediatric surgery used to quantify the functional of the musculoskeletal system in children, and this score is able to give also a subscore, the transmech and basic motility score, that in some ways is able to quantify the autonomy in walking and so on, and in MPS patient this is really reduced. So what happened in mucopolysaccharidosis in the hip joint? This is well described in MPS 1. For example, there are several reporting literature in MPS 1. I'd like to show these X-ray that are taken year by year of the same patient, and we observe a progression in the loss of sphericity of the femoral head, the flat subacetabular that remain flat during the year, the neck diaphyseal angle, and the migration, and finally the migration of the hip. Going more into detail, we can quantify the loss of sphericity of the femoral head with this Moses technique, and we can state that the loss of sphericity in MPS 1 is lost between age 3 and age 3 and 8. So the acetabular index is an index that the orthopedic surgeons use to quantify the coverage from the acetabulum of the femoral head with a quantification of the angle. And we know that in the normal child, this angle is going to decrease with a consequent augmentation of the coverage of the femoral head between the first year of age, more or less between age 2 and 6. While in MPS we observe there are two major works, two major reports about the acetabular index. So one reported that there is no decreasing at all, it stays more or less like this. One reported there is an augmentation, but the important point is that the behavior is different from a normal child, where there should be a decrease with a consequent augmentation of the coverage of the femoral head. What about the cervical diaphyseal angle? I have to say, in a normal person, more or less the angle between the diaphysis of the femur and the neck of the femur is more or less 135 degrees. And in mucopolysaccharidosis, we observe an augmentation of this angle that is going to be almost straight on at the end of the or more or less around 10 years. So no decrease and no hip inside the socket, that the cervical diaphyseal angle is going straight on like this. And so I know that you are familiar with the mucopolysaccharidosis, and so you commonly observe a stiffness of the hip that lead to a movement, a tilting, a forward tilting of the pelvis, and this is another point that make the situation of the hip worse. At the end, what we observe? We observe a migration of the hip that is going outside, and outside. I mean, no coverage from the acetabular. The femoral neck angle is going straight on, and the hip is going outside. This is the result, and so we can quantify it with the Raymar index. This is a percentage that we use to get a measurement of the percentage that is covered, a percentage of the femoral head that is covered by the acetabulum, and we can see that the Raymar index increases between age 2 and age 8. So what can we do surgically for the hip joint? We can act in the femoral part. The femoral is straight on, and we can do an osteotomy like this and put the femoral head inside the socket, like I did in this patient. Usually, when we do a procedure like this in a normal child, we expect a remodeling of the acetabulum. and this is not observed in MPS patients. That's why we can act also in the acetabular part, basically with two kinds of procedure: the pelvic osteotomy, which aim is to restore the correct orientation of the acetabula, or the acetabuloplasty, which aim is not to restore the recovery, to restore the proper orientation of the acetabula, but just to add a piece of roof in order to have more contention from the femoral head. And we, from the literature, we know that we can obtain the best result with a combination of the two procedures, I mean, in both sides, between the femoral part and the acetabular part, because if you perform the surgery only the femoral part, there is no remodeling in the acetabular part, because it's a pathological cartilage, it never ossified, it never remodeled. So if you look at the result of this kind of surgery, of this kind of, let's say, surgical reclustration of the hip, we can see that the results are poor. We have, by the way, only one report of follow-up of MPS 1, and that reported there is a progression after the surgical restoration. There is a progression of the compromission of the joint line, and the patient experienced severe pain. We can discuss a lot because the case area is not homogeneous, because they use the Harris hip score, that is a score that we use mostly to quantify the arthritis. We can discuss if this is the proper score to judge a metabolic patient, but the result is that after a surgical extension of the hip, the value of the hip score are very low. And so when they are young adults, they usually come back asking for a total hip replacement because of the pain. And sometimes it can be quite easy to do a total hip replacement, like I did in this patient. It's a Morgan patient, by the way. I do bilateral total hip replacement, but we can have some difficulty because there is no roof for the femoral head, like I tried to explain before, and so we can have some problem in order to find the proper fitting of the prosthetic part with the bone that is lacking, especially in the top, in the roof of the acetabulum. So we can use sometimes some bony massive transplant or wide cementation or something. And the other problem is that sometimes they are very short, and so sometimes we need some custom-made implant because of the size of the patient. What about the valgus deformity of the knee that is commonly seen in MPS and also in alpha-mannosidosis? We can act during the growing age with the MPS physiodesis, because if we bridge the growing cartilage only in one side, we can block the growing potential medially, for example, letting it grow laterally, obtaining a correction, a progressive correction during the age. But we have to be very careful because of the short stature, these patients are not growing so much. So we have to act very early without expecting the late adolescence, because otherwise there is no room. There is no room for correction. So we have to plan early intervention because correction delays is commonly observed. This is a clinical picture, radiological and clinical picture of MPS physiodesis for a valgus deformity of the knee in a MPS 1 patient. And obviously, we can correct the deformity also in adults, like I did in this case of MPS sick patients. But the surgery is not so solid a procedure like the MPS physiodesis. You know, you need an open procedure full of metal and so on. This is some surgical details with the good result, but the surgery is bigger and bigger. Sometimes we know that there are some anesthetic problems, so we should try to prevent bigger deformity with MPS in children, trying to avoid bigger correction in adults. Also, the correction can be done with the classical osteotomy when the deformity is very severe, like in this case of Morquio syndrome, age 10, because of the severity of the deformity. There was no room for MPS, so I had to perform a distal femoral osteotomy. Later on, they can develop a knee arthritis and so on. And so they ask for a total knee replacement, like I show you for the hip joint. Also, the ankle has a valgus deformity, and in the same way we act for the femur, for the knee, we can act for the ankle, just bridging the growing cartilage of the ankle in one side, obtaining a progressive correction, like I did in this patient with a good clinical and radiological result. So, in conclusion, I have to say that some orthopedic manifestation of mucopolysaccharidosis and alpha-mannosidosis, the orthopedic manifestation of mucopolysaccharidosis and alpha-mannosidosis leads to disability, and the therapies that nowadays are available lead only to an attenuation of the phenotype without a complete resolution of the problem. Nowadays, an early diagnosis is the key for a better prognosis, and I like to underline that some orthopedic manifestation can be the first sign of the metabolic disease. So we have to be very, we have to visit this patient. I say, me and my colleague as orthopedic surgeon, we have to think about the possibility of a metabolic disorder in order to send the patient to the proper specialist. And I have to say that an orthopedic surgeon should be part of the multidisciplinary team, because when we already know that the patient has a metabolic disorder, we know what is going to have, and we can try to prevent major deformity with a simple procedure, especially during the growing age. And so, questions are welcome. So we have a first question. The question is if there are any differences between the hip involvement and the progression of the hip involvement in MPS 1, the difference between MPS 1 and other form of MPS. Yes, so I have to say that most of the literature that are nowadays available is about MPS 1. But there are some reports that allow us to make some difference between the hip involvement and the hip progression in MPS. Usually, more or less 70% of the hips in MPS 1 are involved and are going to lose the sphericity. In MPS 2, for example, more or less 50%, so a bit less. The severity of the loss of the sphericity is the severity is higher in MPS 1, is a bit lower in MPS 2, and there is a faster loss of sphericity in MPS 1. There is a slower loss of sphericity in MPS 2, and the migration at the end is observed in more or less 70% of patients of MPS 1, while only in more or less in 50% of MPS 2. I also to say that there is usually an involvement in MPS 3 of the hip, but that is almost 50% of the patients that are aged at least 10 years have a compromission of the hip in MPS 3. But the problem is that generally when there is a compromission of the hip, they are really poor condition, and so there is no room for surgery. There are some reports in literature about, there is only one report about total hip arthroplasty in MPS 3, and there are some reports about steroid injection because usually they have poor condition, and so there is no room for a major surgical intervention. I also to say that there are some reports of in MPS 6 because the hip joint is always involved in MPS 6, but generally they are pain-free. The symptoms are not so severe, and generally there is a low tendency to migration. I have to say that in MPS 3, the role of surgery is not so, it's not clear until now. So if there are other questions. Yes, the other question, the following one is, if you can you resume the precocious musculoskeletal signs, symptoms suggestive for MPS? Yes. So as an orthopedic surgeon and as a general practitioner, there are some musculoskeletal signs that are really uncommon in children and should be and we should think about a metabolic problem when we are facing with a child with this kind of symptoms. And these symptoms and this sign are the joint stiffness, that is generally a symmetric one, without any pain, without any sign of inflammation. In case of symmetric painless stiffness, think about a metabolic disorder, think about a mucopolysaccharidosis. In my experience, one of the experience time is the lack of pronosupination of the elbow. Another sign, another very uncommon situation is the carpal tunnel syndrome. A child with a carpal tunnel syndrome is really an uncommon situation. Think about a mucopolysaccharidosis every time that there is a child with carpal tunnel syndrome. Another point is the trigger finger. I mean, I repeat, the trigger thumb can be easily seen in a child, but a trigger finger that is not a thumb is really uncommon in a child. So in presence of a trigger finger that is not a thumb, think about a metabolic disorder, think about a mucopolysaccharidosis. And the other point is the spine deformity with special reference to the thoracolumbar kyphosis. That, by the way, is not pathognomonic of mucopolysaccharidosis because it can be also seen in achondroplasia, for example. But this situation, I mean, the thoracolumbar kyphosis in a child is really uncommon. So, in presence of a thoracolumbar kyphosis in a child, think about a problem, can be achondroplasia, can be a metabolic disorder, but send the patient to the proper specialist. Other questions? Yes. Which is the proper timing for epiphysiodesis in mucopolysaccharidosis or alpha-mannosidosis? So, as I said before, they are short. I mean, mucopolysaccharidosis patients are short and they have a short stature, and so there is no growth expectancy. So we should act earlier, and especially in MPS 4 and MPS 6, we should act very early. I have to say, in MPS 4, we should perform an epiphysiodesis around the knee around age 4, more or less. In MPS 6, around age 6 or not later than 6. In MPS 1, especially if they underwent bone marrow transplant and so they are growing a bit more, we can wait until 7, 8. And about alpha-mannosidosis, since we are commonly dealing with attenuated cases and there is no short stature, we can wait until 7, 8. So in more acute patient MPS 4, we should act with epiphysiodesis very early, around 4, around 6 in MPS 6, and we can wait until 7-8 years old children in MPS 1 or MPS or alpha-mannosidosis. So I see there are no more questions. So it was a pleasure, and have a nice time. Hope this webinar is useful for you. Bye bye to everybody.